Hello, everyone. Welcome. My name is Gary Parker. I'm the Associate Dean for External Affairs at the Brown School, Washington University in St. Louis, where I also have the great privilege of serving as the director of the Clark Fox Policy Institute. And welcome to Open Classroom. It's an opportunity for the Brown School to open its virtual doors and allow you an opportunity to hear from some of our incredibly talented faculty on a number of different areas of real interest. I want to let you know about an event that's coming up on Thursday, this Thursday at 10 a.m. We are having a panel co-sponsored by the Clark Fox Policy Institute. It's part of their COVID-19 and race series, and this one will focus on educational equity in a new era. This will feature the Superintendent of Schools for University City, the Executive Director of Student Services from the Rockwood School District, the Founding Director of EdHub STL, and the Superintendent of the Jennings Schools District. For those of you who are joining us outside the St. Louis region, those are pretty heavy hitters in the educational arena here in St. Louis. We have almost 800 RSVPs for that lecture as well. So we want to encourage you to sign up. I'll put a link in the chat feature so that you can sign up. If you aren't able to register in time, you're always welcome to follow us on the YouTube where we simulcast this lecture live. I want to thank my co-host and amazing colleague, Janet Gillow, who's our Director of Professional Development, for everything that she's been doing, putting together the Open Classroom series. Before I hand it off to her, I just want to share with you that we have disabled your cameras and your microphones so we can't see or hear you, but we do want you to be a part of the conversation. So please send us your thoughts, your questions using the chat feature. We've also found that a lot of our attendees have posted links to different resources that they thought other attendees might find useful. If you want everyone to receive your chat, you just need to change the feature from all panelists to all panelists and attendees. That's at the little box right above where you would type your comments. So without further ado, I'd like to introduce Janet Gillow.
Thanks, Gary, and welcome everyone. It's my great pleasure to introduce today's discussion. We have two presenters who are both amazing clinicians and amazing educators, so you're really in for a treat today. Dr. Megan Keyes is a clinical psychologist who specializes in assessment and treatment of PTSD. She has over 20 years experience in the trauma field. She's on our adjunct faculty at the Brown School, and she's also the founder of Trauma Empowered Consulting, which provides education and consulting services to professionals working with trauma survivors. And she's joined by Dr. Julie Mastnak. She's a senior lecturer at the Brown School and has nearly 15 years of clinical experience treating PTSD with evidence-based psychotherapy. Together, they are half of the faculty that lead our postmaster certificate in assessment and treatment of PTSD in adults. So two specialists, wonderful human beings and friends of mine here today to talk to you about increasing client engagement with evidence-based psychotherapy for PTSD during a pandemic. Please welcome Julie and Megan.
Well, thank you so very much for that warm welcome. And thank you for the opportunity to be here today. Talking about trauma recovery is one of my favorite things to talk about. And so I truly have been very much looking forward to this opportunity. So part of what drew me to this lecture is that I think there still is a residual misconception that PTSD is a chronic condition that can't be effectively treated. And the concern with that misconception is that it can have implications where some people who have PTSD may not be getting the help that they need. And so I am grateful for any opportunity to spread the word that PTSD psychotherapy treatments are effective. And we're going to be talking about that truly with the spirit of spreading hope and recovery throughout the course of the lecture today. As Dr. Keyes and I prepared for this lecture, we share the position that we really do believe that everyone with PTSD, whether the source of trauma is an interpersonal assault or a sexual assault or combat trauma or a natural disaster or an accident, that anyone struggling with these symptoms needs to know that treatments really do work and can lead to a better quality of life, and that these treatments can be available even in the context of a pandemic. And so that led us to the presentation today, which is about increasing client engagement with evidence-based psychotherapies for PTSD during a pandemic. Our most sincere hope is that this will be helpful to the people listening to the webinar today, and also that it will increase access to these important and effective treatments for PTSD. So welcome. We are very excited to spend the next hour with you. So before we jump into content, there are just a couple of caveats that I want to go through very briefly. So first, I just want to note that Dr. Keyes and I are both employed through the VA, although just to be very clear, the presentation today is in no way affiliated with the VA. I also just wanted to mention that we're not going to be talking today about any of the legal or regulatory or HIPAA-related issues to providing telemental health. As we all know, those issues are incredibly important, just outside the scope of this presentation. We only have 60 minutes together, and I have a suspicion that that 60 minutes is going to go incredibly quickly. So our encouragement is simply to check with the agencies and regulatory bodies just to make sure that you're clear about the rules around telehealth for your state and your profession and practicing within the scope of your license. And the last piece that I want to mention just before we jump in is that when we talked about this presentation, it probably could have been titled Increasing Client Engagement in Evidence-Based Psychotherapy for PTSD During a Pandemic When Clinically Appropriate. And I add that piece in now because we fully recognize that the pandemic has impacted clients in different ways. And some of your clients may be struggling with financial insecurities. They may be struggling with new childcare demands. They may be struggling with acute health concerns. And so, as always, the message today is simply to make sure that you're talking with your clients about available treatment options, but engaging in shared decision-making so that the focus of treatment is really what's going to be most helpful for that client at that time, right? And if the conclusion is that what would be most helpful would be an evidence-based psychotherapy for PTSD, to know that that can safely and effectively be delivered even during a pandemic. And so that's what we're going to be talking about today. We're going to kind of jump in here. We've got a very kind introduction about Dr. Keyes and myself. In terms of where we go as a roadmap, you know, we talked very extensively about how to make this most helpful for our audience. And we intentionally decided that we wanted to open this up to a broad audience, as broad as possible. The challenge with doing that is that then we had to have some discussions about how do we balance breadth of content with depth of content. We really want to ensure that everyone listening in today, whether you are brand new to trauma work and simply curious about the topic, or whether you are a seasoned trauma therapist, that everyone might take something away from this discussion, right? And so it's with that in mind that we set the outline for today, that very intentionally, we're going to start by talking about broader content. I'm going to be introducing an overview of evidence-based psychotherapy for PTSD. And then as the lecture goes on this afternoon, it's going to become increasingly specific, with Dr. Keyes talking about very specific suggestions for implementing some of these interventions during a pandemic. So that's kind of the outline of where we're going to go, starting by talking about an overview of evidence-based treatments for PTSD, talking about some of the challenges for how do we do this in the context of the pandemic, and then really ending on a note of problem solving and thinking about some solutions to these challenges. And we will certainly do our very best to allow time for questions and interactions at the end. So if I were to do this in person, right, I always like to get to know my audience. It's much more difficult to do that in this setting because I cannot hear or see you. And so what we thought might be helpful was to just take a quick kind of temperature of the audience by asking a polling question. And so I'm going to ask for Janet to help here. And the polling question is basically to just ask how much basic knowledge you have about evidence-based treatments for PTSD. Would you say you know basically nothing, you know a little bit, you know some, quite a bit, or you're actively implementing these treatments in your practice? Janet, I'm quite impressed with the technology. This seems to be working.
It does, and we love everybody weighing in. We'll give folks maybe 20 more seconds to let us know if they're familiar with evidence-based psychotherapies and which ones they're using. Both questions launched.
All right, we'll give folks a few more seconds. Thank you for responding. This is really helpful because it does give a sense of where people are starting and what we can do to be most helpful here. All right, fantastic. So we've got really responses across the board, right? So folks in the audience, that this is brand new content, so welcome. I hope this is going to be very exciting to you. All the way to folks that are actively implementing this. About 15% of the folks on the call are actually using these treatments. So again, I hope that our strategy of trying to have a takeaway for everyone will be helpful for you. All right, well, let's jump in then and get started. And again, I'm going to start by talking with some more broad content. I decided to include a slide on the diagnostic criteria for PTSD and DSM-5. I know that this is probably familiar content to everyone on this call, but I thought it was important because when we talk about evidence-based treatments for PTSD, those treatments really are predicated on accurate assessment and diagnosis. So we need to set the frame for this discussion by making sure we're clear about what the criteria for PTSD look like in our clients. And as we're all familiar, right, there's the symptom constellation of the 4 clusters: the intrusion symptoms, the avoidance symptoms, the changes in thoughts and mood, as well as some of the changes in reactivity and hyperarousal. And as we all know, those symptoms result in PTSD, right, from exposure to a criterion A stressor. And DSM-5 has a more inclusive definition of a criterion A stressor than in previous versions of the DSM, right? So we're looking at a person that is exposed to death, threatened death, actual or threatened serious injury, or sexual violence by either experiencing the event, witnessing it happen to someone else, learning that it happened to a close family member or friend, or being exposed to the details of the event. Okay. So for those of you who are in that kind of basically nothing category, that this is brand new content, my hope for you is that this slide will be the most important of all of the slide deck, because it talks about this concept of recovery from PTSD. So when we look at the research, what we know is that many people, most people, report PTSD symptoms in the immediate aftermath of a trauma. What we also know is that often these symptoms remit and improve with time, even when there's no treatment. So if you think about our language, sometimes we'll use the saying that like trauma or time heals all wounds, right? The sense that often with time, these symptoms remit. The idea is that when there are PTSD symptoms present, something has interfered with the recovery process, right? I often talk to my clients about the analogy of a physical injury. So I'll talk to them about the idea that if you cut your hand, for example, your body wants to return to a state of health. That's our baseline. So if you cut your hand, your body will bleed, it will clot, it will scab, it will scar. Your body has the innate wisdom to bring itself back to a state of healing under the right conditions. Now, there are certainly times where things happen, where maybe you get dirt or bacteria in that wound, and it's a different trajectory. But in general, the body wants to be to a state of health. And the idea is that this can be an analogy for psychological injuries as well, that our minds want to go to a state of health. They want to go to a state of balance. But sometimes, just like things interfere with the physical healing process, things can interfere with the emotional healing process. And our current understanding is that 2 of the most notable factors that interfere with natural recovery, with natural healing, are avoidance and cognitive distortions. And so the basis of our evidence-based psychotherapies for PTSD very intentionally target the avoidance and the cognitive distortions to allow that natural recovery process to take place. And so you'll hear us talking about that kind of throughout the discussion today, okay? So as we move a little bit further along, right, I want to just, again, broad brushstrokes, talk about some of the treatments that have the strongest evidence for being effective in treating symptoms of PTSD. And if we look at the VA and DoD practice guidelines to get some information, right, what we find is that there are several treatments that have quite a bit of research evidence. Cognitive processing therapy, prolonged exposure, and eye movement desensitization and reprocessing. Just in terms of respecting time and scope, and also really highlighting the interventions that Dr. Keyes and I have the most clinical experience in, we're really going to be focusing on cognitive processing therapy and prolonged exposure for a bit more of the lecture today. I am curious from the polls, Janet, can we scroll down here? How much experience do people on the call have with implementing these interventions? So it looks like about 28% of the participants have used CPT in their practice, about 13% PE, about 10% EMDR, 19% have used another protocol, and a good half of the participants aren't using any evidence-based treatments currently. So again, we've got a nice spread here. So just very briefly then, I do want to talk about cognitive processing therapy and prolonged exposure and share some resources before I hand things over to Dr. Keyes. So for those of you who are brand new to CPT, taken directly from the website, CPT for PTSD, the treatment is described as follows. CPT provides a way to understand why recovery from traumatic events is difficult and how symptoms of PTSD affect daily life. The focus is on identifying how traumatic experiences change thoughts and beliefs and how our thoughts influence current feelings and behaviors. An important part of the treatment is addressing ways of thinking that might keep individuals stuck and get in the way of recovering from symptoms of PTSD. So if we think about just kind of a logistical overview, right, in a nutshell, what we know about CPT is that it is time limited. It can be delivered usually over 12 sessions, about 50-minute appointments, and can be conducted either in individual or group therapy formats. And when we look very specifically about what the mechanisms of action are, the mechanisms of change, you'll recall that just a while ago I was talking about recovery from PTSD, and I mentioned that cognitive distortions can be one of the elements that interferes with natural recovery, right? So some of the beliefs, some of the things we tell ourselves, maybe about why the trauma happened, or some of the things we tell ourselves about ourselves or other people or the world. At its heart, CPT really focuses on helping clients learn skills to think about and begin to challenge some of those unhelpful beliefs. So that's kind of the heart of CPT. Now, I wanted to make sure that folks on the call had access to lots of resources, and so I just want to run through these briefly. The first bullet point here, the CPT homepage, is a website that is actually hosted by the authors of the protocol. So I certainly would encourage you to look at that as a resource. The National Center for PTSD is another phenomenal resource. It includes not only patient education, but also an article database. There's lots of continuing education courses, as well as apps and videos that can be really helpful in clinical practice, especially in terms of engaging clients and helping them understand the rationale for this treatment. There's two other resources I want to speak to briefly. This resource right here, right, comes from the Uniformed Services University and Center for Deployment Psychology. It's a training that's about 75 minutes or so, but will give you a bit of a more in-depth overview of CPT than what we can do in this call today. And finally, the last resource on this page is a link to the website for the Medical University of South Carolina. It's in partnership with the National Crime Victims Research and Treatment Center. And they do a fairly extensive training in CPT. I believe that the online training is close to 9 or 10 hours. So for those of you who are looking to do more extensive training, that certainly would be a resource to take a look at. I also want to talk a bit about prolonged exposure. And again, if we look at the National Center for PTSD, the way that they describe prolonged exposure just briefly is that it teaches clients to gradually approach trauma-related memories, feelings, and situations that they've been avoiding. And the idea is by confronting the challenges, clients can decrease symptoms. So if we look at a brief overview of just what PE looks like in practice, it is also recovery focused and time limited, often delivered in 90-minute sessions over 8 to 15 sessions, and delivered in an individual therapy format. And when we look at main components, and again, mechanisms of change, as I mentioned before, right, not only cognitive distortions, but the avoidance can really interfere with the natural recovery process. And PE is structured to confront the avoidance, both the avoidance of the trauma memory, as well as avoidance of reminders in the here and now. And the heart of PE is really that through repeated exposures, habituation occurs, right? So clients really learn that the memories and the exposure to reminders aren't dangerous, and they learn that they can tolerate the distress. And again, very similarly to what I did with CPT, I just want to outline some resources for those of you who are interested in learning more. Again, here is the PE equivalent on the National Center for PTSD website. They have a great whiteboard video that actually is kind of walks through what the treatment looks like. And then again, 2 additional trainings. The training through the Center for Deployment Psychology is a little over an hour, and again, a much more in-depth training through the Medical University of South Carolina. Okay, so at this point, I am going to hand things over to my colleague, Dr. Keyes. And the idea is that now we've got a sense that there really are effective psychotherapies for PTSD. What are some of the barriers to delivering those treatments in the context of the pandemic? And before I hand it over to Dr. Keyes, I just wanted to open it up to the audience and ask you, please, for some ideas and some brainstorming. So in your practice, if you can just type out a few ideas or thoughts, just brainstorm, what are you seeing as the primary barriers to delivering these interventions during the pandemic? And Janet and Gary, if you can help us, because we can't see the responses, but I'm curious to hear what our audience is saying.
As you all are reflecting on what's challenging with engaging with clients right now, we've got limited providers, limited training, inability to access services that are there, and not ample health care as possible barriers.
Okay.
Not being in person to ensure safe symptom management.
Mm-hmm.
One thing that comes to mind is accessibility of resources in other languages.
Oh. Mm-hmm.
Here, my PTSD clinic is actually doing more CPT and PE during COVID than we were pre-pandemic. A ton of telehealth and using PE coach and CPT app. Cultural differences.
Mm-hmm.
Most practice only apply to certain group or population. Lack of privacy at home and childcare. Lots of great ideas coming in from folks. Very much for the address.
Well, and I'll tell you, very much aligns with some of the ideas that Dr. Keyes and I came up with as we were preparing for this presentation. And so at this point, I will hand it over to Megan to talk a little bit about some of these key challenges.
Okay, thank you, Julie. So we're going to start with talking about some of the key challenges of engaging clients in trauma-focused therapy. One thing to keep in mind. Oh, I'm sorry, Julie, can I have the next slide?
Yes.
Sorry.
There we go.
One thing to keep in mind is that some of these barriers are not necessarily unique to trauma-focused therapy, but may be common barriers to engaging clients in different types of mental health treatment. However, it is important to understand how some of these challenges may be experienced by or impact an individual with PTSD. All right, so in terms of a common logistical barrier, CPT and PE are both time-intensive protocols in which the bulk of the treatment takes place outside of the weekly therapy session in terms of daily homework or between session practice. Thus, it can be very helpful to have a discussion with your client about realistic expectations in terms of their ability to engage in this type of treatment at the current time. Research indicates that about 80% of individuals with PTSD have at least one comorbid mental health disorder. It's important to keep in mind that we are typically able to progress PE and CPT in such circumstances. However, on occasion, the severity of that comorbid mental health disorder may need to be addressed ahead of time. And some examples of that include individuals with severe depression, frequent panic attacks, or self-injurious behavior. Although stigma is a common barrier to mental health treatment, it's important to remember that self-blame and feelings of guilt and shame are common trauma reactions as well as potential symptoms of PTSD. It can be very helpful to normalize and validate these concerns for your client, but also to highlight that PTSD may be contributing to the severity of these symptoms, and these may well change over the course of treatment. And finally, some individuals just aren't fully aware of the degree to which PTSD is really impacting their functioning in terms of their thoughts and feelings and behaviors. Therefore, psychoeducation around common reactions to trauma, as well as how difficulties functioning may be associated to PTSD, can be really helpful. All right, so we know that avoidance is a key barrier to engaging in trauma-focused treatment. However, it is important to consider what specific fears or concerns may be contributing to the avoidance. First of all, it's important to remember that for many individuals, avoidance is the most effective way they have found to manage their PTSD symptoms. Therefore, the idea of no longer avoiding, but instead approaching these distressing memories and thoughts and feelings may be incredibly frightening for your client. Some individuals fear that no longer being able to rely on avoidance as a way to manage their anxiety could result in a significant worsening of their symptoms. And finally, that fear of loss of control can occur in multiple ways. Some individuals may fear losing control of themselves while directly engaging in the trauma-focused work. They may fear having a breakdown or needing psychiatric hospitalizations. Some individuals, due to concerns about symptom exacerbation, may fear losing whatever level of functioning they've managed to achieve by relying on those avoidance-based coping strategies. And finally, some individuals may be concerned that they will be, quote, forced to participate in trauma-focused work once they've committed to one of these protocols. So psychoeducation can be very helpful in addressing these concerns, but it's also really important to highlight for your client that psychotherapy is a collaborative process, and your client absolutely plays a role in the selection of their treatment, as well as the progression of their treatment going forward. Okay, so pandemic-related research indicates that a chronic stressor, such as COVID-19, may have a negative impact on an individual's mental or physical health. For individuals with PTSD, it's important to understand that some specific aspects of this pandemic may exacerbate key symptoms or trauma reactions.
Okay. Did I advance too quickly?
Nope, you're good.
Okay.
So in terms of common logistical issues, those first two bullet points really refer to common pandemic-related stressors that may end up limiting your client's ability to participate in therapy, either due to additional distress or additional time commitments. So those variables are very client-specific and just need to be fully explored on a case-by-case basis. Social distancing may result in teletherapy being the only option for treatment, and that may pose an obstacle depending upon your client's willingness and ability to engage in that mode of treatment. It's important to remember that for individuals with PTSD, routines often provide a great sense of security, and routines can actually be used as a way to kind of actively manage stress and anxiety. Since routines do allow a great degree of predictability, when this is disrupted, it can potentially result in significant distress for the person. And finally, again, social distancing and other safety measures may prevent your client from engaging in a wide range of activities. But it's important to remember that some of those activities may have been serving as coping strategies, going to the gym, attending religious services. Once removed and your client's no longer able to engage in those activities, to whatever degree those activities were helping the person manage their stress or other mental health symptoms, those issues may well increase. All right, in terms of emotional and behavioral issues to keep in mind, individuals with PTSD often have significant concerns about their own safety, but those concerns can also apply to the safety of loved ones. So in the context of a global health threat, your client may well be experiencing significant health anxiety for themselves as well as others. In terms of uncertainty, it's important to remember that we are in the midst of a rapidly evolving global health crisis. New information is consistently being conveyed, and most people are needing to repeatedly adjust their expectations, decisions, and behaviors accordingly. For a person with PTSD who may really struggle with the unknown, living day to day in these uncertain circumstances may be a profound challenge. Sheltering in place with partners and family members may result in increased conflicts. Although some individuals tend to be socially isolative, this is typically by choice. When isolation is imposed on them, they may well experience feelings of loneliness or loss of connection to others. Avoidance as a coping strategy for PTSD sometimes involves keeping oneself very busy. When unable to engage in regular activities and remain occupied, PTSD symptoms can sometimes increase. It's important to remember in the context of this pandemic, individuals may be experiencing multiple losses and possible grief reactions. The losses may be personal in nature, such as the death of a loved one or the loss of a job, but there are also shared losses that most people are experiencing as a result of the pandemic, such as the loss of certain freedoms, the loss of an ability to plan for the future. This can be a really useful domain to investigate and explore with your client, especially if that person's trauma history involved a significant loss. And finally, research indicates that pandemic may exacerbate existing mental health conditions as well as trigger the onset of a new one. Therefore, this is just an important area to keep an eye on and potentially monitor. So these are just a few key issues to keep in mind if you are considering providing psychotherapy via telehealth. The one that I really want to highlight is the first bullet point. This is essentially our gatekeeper in terms of technical access. Is it even feasible for your client to be able to participate in this mode of therapy? Dr. Mastnak is going to discuss the clinical and logistical issues in a bit more detail in just a moment. And bulk of the research that has been conducted to date on PTSD being implemented via telehealth has been conducted with veterans. I just wanted to highlight some of the key research findings. In terms of telehealth, research indicates that most clients are willing to participate and do end up liking it over time. Several key treatment variables are similar across both modes of delivery, telehealth and in person. Therapists can maintain adherence to manualized protocols when implemented via telehealth. And finally, both CPT and PE have been effectively delivered via telehealth with similar outcome results to in-person delivery. All right, so now putting all the pieces together, How do we, and what is the primary challenge of engaging clients with PTSD in a trauma-focused EPB during a pandemic via telehealth? And the central challenge is really posed in that question at the top of the slide. How do we treat PTSD when anxiety, isolations, avoidance, and hypervigilance have become the norm? PTSD treatment typically targets these hallmark symptoms, and we're now living with a global health threat in which some of these things are understandably being encouraged and reinforced. The key issue throughout treatment is going to be to attempt to determine and understand to what degree COVID-19 and your client's PTSD symptoms are impacting each other. And we'll be discussing that a bit more in the slides to come. It's also really important to remember that you and your client are sharing this experience of living through a pandemic, and you both may be impacted by some of the same stressors. So it can be worthwhile to just consider to what degree you may be comfortable with self-disclosure and wanting to discuss any elements of the shared experience over the course of therapy. All right, so now we are going to swap over to problem-solving mode and talk about some potential solutions to these various challenges. And again, I just want to highlight some of the things that we'll be discussing are not necessarily limited to clients with PTSD, but may be able to be utilized with a range of clients and other types of therapy as well. All right, so these treatment planning issues may apply to new clients as well as current clients. First and foremost, what is it that your client really wants and needs at this specific time? To what degree is COVID-19 impacting them? Is the pandemic taking center stage in terms of presenting concerns, or do other issues remain their primary focus and reason for progressing therapy? Number two is back to the basics of feasibility. Given the various challenges we've highlighted, how realistic is it that your client could engage in and hopefully successfully complete one of these protocols at the current time, given their specific circumstances? The collaborative process of shared decision-making is critical when determining if your client is going to progress trauma-focused therapy. We very much want the person to feel empowered to make this decision and to understand that it is their choice. However, we do need to emphasize a certain level of flexibility in light of the current pandemic. Sessions may need to be scheduled due to emergent issues. Telehealth and technology is not 100% reliable, and sessions can get disrupted at times. Contingency planning needs to be a regular part of treatment planning, as well as the ongoing treatment process. The fourth bullet point I personally feel is the most important and the one that I really want to kind of drive home the most strongly. We don't want to jump too quickly into ruling out EBPs due to difficult circumstances. These evidence-based therapy protocols remain our best option for treating PTSD. CPT and PE teach our clients a set of skills that not only address PTSD symptoms, but that they can use to navigate real-life struggles. These skills can be applied to new stressors, difficult decisions, and troubled times. Therefore, the decision to engage in a trauma-focused treatment during this pandemic is not just about gaining relief from PTSD symptoms, but it's also about acquiring a helpful skill set that that person can use going forward. And finally, due to the evolving nature of the current pandemic, ongoing observation and assessment of your client's symptoms and needs is recommended. Okay. And these are just some key issues to keep in mind as treatment progresses. Those first two bullet points, again, are kind of referring to that reciprocal relationship between COVID-19 and your client's PTSD symptoms. How are these two variables impacting each other, and does that relationship change over time? As your client's PTSD symptoms decreased over treatment, are they responding to and thinking about the pandemic-related stress in a different way? As your client feels more capable of managing the pandemic-related stressors, is this having an impact on their PTSD symptoms? The third bullet point really drives home the idea that life does not stop because we're doing trauma-focused therapy. Life goes on and life sometimes gets in the way. And at the current time, given that we are dealing with a worldwide pandemic, it most likely is impacting your client in multiple ways. So it's really important to acknowledge that and to encourage your client to use adaptive coping skills to try to minimize the impact of this chronic stressor. Again, due to evolving circumstances, ongoing kind of monitoring and checking in is going to be critical. And finally, encouraging your client to use some various types of self-help tools, including mobile apps, is a great way to help support them in using adaptive coping skills. Two apps that I'd like to highlight were both developed by the National Center for PTSD. They are called PTSD Coach and COVID Coach. Both of these apps allow the individual the option to kind of track and monitor symptoms over time. Both apps provide a good amount of psychoeducation about PTSD or the mental health impact of COVID-19. And finally, most importantly, each of these apps provide a range of adaptive coping skills that your client can learn and utilize over time.
Wonderful. So in the spirit of continued problem solving, if you and your client arrive at the conclusion that the time is right to move forward with an evidence-based psychotherapy for PTSD during this time, there are a couple of practical strategies that we thought were just important to be thinking about. And again, just in the interest of time, we can't cover everything, but I do want to spend a little bit of time talking about patient safety, as well as the importance of creating an appropriate therapy setting. So as we all know, and as came up in the brainstorming session, obviously patient safety should be our first and foremost consideration. It is just inherent in everything we do, inherent in our professional ethics. It becomes even more important when we're talking about the potential of delivering services through a telehealth platform. And so I'm going to offer just some general ideas and things to consider. Some of these may be very specific to your agency or to the platform that you're using. But in general, the idea is really to be proactive when it comes to patient safety. So some of the things that you might think about, for example, are identifying an emergency contact and even having assigned release of information at the onset of treatment. So that again, there's a clear plan in place about who to contact should an emergency arise. The other thing to really consider is making sure that at the beginning of every appointment, you're confirming the client's location. Again, really important that you know in what physical space the client is in case you would need to get emergency medical or mental health services to the client. And finally, it's just important to consider really developing an emergency plan in advance. Again, the spirit of all of this is being very proactive, that should there be a need for emergency services, both you and your client have talked through this and you know exactly what to expect. There are also some other practical kind of problem-solving things that are important to do just in terms of creating an appropriate therapy setting. So one of the things I think we take for granted is that in in-person therapy settings, right, there is time, there is space, there is privacy, just inherent in that setting. When we talk about delivering those services through a telehealth format, we have to be intentional about creating an appropriate therapy space. I have very often talked to my clients about the idea that I think it's helpful to think about telemental health appointments just as they would think about face-to-face appointments, right? And what that means in the context of the current pandemic, where more people may be working from home or more children may be doing schoolwork at home. What that means is that it's more likely that there can be distractions by family, by pets, by telephones ringing. And so there has to be an intention to create time and space and privacy so that there is that safety to be able to effectively engage in these treatments. The other practical thing to simply think about is for many of these psychotherapy treatments, there are actually materials that accompany the protocols and homework assignments, right? And so thinking about how you can safely, effectively, and privately be able to distribute those materials to the client is something that's important to think about and problem solve in advance.
Okay, so for the sake of time, I'm just going to kind of briefly touch on this slide. Motivation enhancement and kind of exploring your client's motivation for therapy prior to starting treatment can be very useful for both the clinician and the client, especially if the client is struggling with feelings of ambivalence or conflicted feelings about progressing therapy. This can also be a very helpful approach to return to over the course of therapy if your client is struggling in some manner. Maybe they're experiencing symptom exacerbation and questioning the utility of treatment. Maybe they're struggling with poor attendance or low homework compliance. The 4 domains that I have listed there are key areas that you can explore with your client as a way of enhancing motivation to engage or progress treatment.
Okay, and I will be respectful of kind of bumping close up against to the time limit here, but I do want to talk a little bit about how to appropriately acknowledge health concerns if you are delivering these treatments. So if we go back full circle to some of the concepts we talked about earlier in this lecture, the idea that avoidance and cognitive distortions interfere with natural recovery, and that those are really some of the targets of treatment. The idea is that there are some nuances in terms of how to effectively deliver those therapeutic tasks during the pandemic. So, for example, if we think about some of our interventions that target avoidance, we know that in vivo exposures can be particularly effective. Now, some of the challenges with that are that in this truly unique time, as Megan mentioned, that isolation, avoidance, and anxiety are pretty normative, right? And often those of you who have had experience with PE will probably resonate with the idea that often in vivo exposures target things like going to public places, right? Targets that the current pandemic is absolutely going to limit. And so what I offer today is it's just important to consider alternatives and to think creatively. So it may be that with a client in particular, you're continuing to do exposures, but you're looking for online stimuli. So maybe Google Images or maybe YouTube videos. It may also be that instead of doing true in vivo exposures, you're doing more behavioral activation and encouraging clients to build, a garden in the backyard or to be going for a hike. I also offer, and I'll often tell my clients, right, that the spirit of PE is very much about a paradigm shift, a shift away from the language of I can't, right? I can't go to the grocery store. I can't drive at night. I can't. To a paradigm that says I can. I can do this and I can tolerate it. And so even if we have to be creative and think outside of the box about how to deliver these exposure interventions, I think it's still possible to do that in the spirit of this treatment. I also want to speak a bit about some of the nuances to doing cognitive restructuring, right? So again, we talked before about how some of those cognitive distortions can really interfere with natural recovery. And I think it's also important to acknowledge that it's possible that what's happening with the pandemic can actually be reinforcing some of those unhelpful cognitions, right? Beliefs like the world's not safe, or if I get close to others, I'll be hurt, may be reinforced by what's going on currently. And so I just remind you that the overarching goal of cognitive restructuring is really to help our clients develop accommodated beliefs. Accurate, balanced beliefs. And we can do that whether we're talking about accommodated beliefs related to the trauma experience itself or accommodated beliefs about current stressors. As Megan pointed out before, in these treatments, we're really teaching skills that are intended to be helpful for the client's life, right? Not only in response to the trauma, but in response to current challenges that our clients are facing.
So as we mentioned before, life does not stop for trauma-focused therapy, and sometimes life events or stressors can pop up that may exacerbate a client's symptoms or levels of distress. So this, and especially in the context of the current pandemic, this is just an important thing to be able to be aware of, and just to be able to have kind of direct discussions with your client about what may be driving their level of distress or symptom exacerbation in a given week. If a significant stressor pops up that does need to be addressed, that collaborative process of shared decision making is really important in terms of determining how you can best meet your client's needs. If bottom line is this is an imminent issue that needs to be addressed today, we do have the flexibility within these treatments to do an off-protocol session to meet our client's needs. However, I would just strongly encourage still carve out some time to review the homework that they completed the previous week and reassign new homework, because as we said, these protocols are really about developing a set of skills, and we want them to be able to keep progressing skills acquisition. And finally, if for any reason trauma-focused therapy does need to be put on pause or discontinued, at whatever point you are in the protocol, it's incredibly useful to review with your client what they have learned to date, if they have developed any helpful skills, and how they can continue to utilize those going forward.
So we are near time. I told you at the onset of this that I had a suspicion that our 60 minutes would go by very quickly, and indeed it has. So we want to leave this discussion with just a little bit of room to talk about some resources, to maybe field a question or two, and also to ask you for what you will take out of this talk. But what Megan and I offer, again, is that the true intention of this lecture today was to create a sense about hope and recovery related to PTSD. And our hope is that what you take away from this talk is just a reminder that psychotherapy for PTSD truly is effective. Treatment works. And it is possible, even in the context of the current pandemic, when it's the right fit for your client, to know that you can safely and effectively access these treatments for your clients.
Okay, and I just want to speak for a moment about this resource for clinicians. So the National Center for PTSD does have a PTSD consultation program, which typically offers free consultation for mental health providers working with veterans with PTSD. However, in times of national crisis, they expand this program and make this resource available to any healthcare provider who would like to consult with an expert on the mental health effects of COVID-19. So if you go to this website, in order to reach out to a consultant, it's just a matter of placing a phone call or sending an email, and they will respond to you. In addition to the consultation services, this program offers monthly webinars. You can sign up to be notified of the topic each month, and they do have various online PTSD resources for providers. All of the slides in this presentation that had the reference Norman et al. At the bottom was from a lecture in this series that was done in March on treating PTSD during a pandemic. I highly, highly recommend viewing the lecture if you get a chance. They do go into a more detailed description of how to implement CPT, PE, and EMDR during COVID-19.
And if you are interested in learning more, as Janet mentioned during the very warm introductions, both Dr. Keyes and I are two faculty members that teach the Postmaster Certificate Program in Evidence-Based Assessment and Treatment for PTSD in adults. And if you're interested in learning more about that as an additional educational opportunity, we've included the link here for your review. So I think we are near the end. Janet and Gary, how did we do with timing, and do we have any space left for questions?
Just a little bit of space for questions. Wonderful audience, an audience after your own heart, very interested in what is the evidence base for a variety of interventions. So with just about 3 or 4 minutes for questions, what I'm hoping to ask you to comment briefly. Folks were asking about a few different interventions and wondering from your perspective as specialists in trauma, what you knew about evidence-based for them. So a curiosity about internal family systems for folks that have a PTSD diagnosis. Any comment on that evidence base at this time?
So that is a tough question to answer with just a little bit of time left. I think what I would encourage folks to do, especially if there's lots of questions around this, to reference both the National Center for PTSD's website as well as the VA DoD practice guidelines for treating PTSD. Those are great resources that not only outline evidence-based psychotherapies, but talk about the research base for different types of treatments. And I think those resources can answer that question much more fully and accurately than what we'll be able to do in just a couple of minutes. Megan, would you add anything to that?
No, I was just going to highlight that on the page that looks at PTSD treatments, in addition to the 3 that we noted, they do cover about 4 or 5 others that still have a fair amount of evidence behind them, such as trauma narrative therapy and written exposure therapy. So you can learn a bit more about some of the emerging treatments that have at least some amount of evidence behind them on that website.
Sounds good. So just one other question, which doesn't get to a specific modality, but we have a couple of folks wondering about the appropriateness of using the evidence-based interventions you talked about in group versus individual therapy. Thoughts about whether this is appropriate to group settings as well.
Megan, do you want to take that one?
Yeah, so with CPT, there has been a body of research that looks at it being implemented in group and have found it to be effective. Within a group context, I think you will want to be careful in terms of if certain clients may not be a good match for CPT. In general, our kind of general rule of thumb with CPT is that for individuals where there may be safety concerns or there may be a comorbid psychotic disorder, we typically don't consider those the best match for a trauma-focused therapy. In terms of PE, it is still largely viewed, and most of the evidence falls behind individual therapy for that one, especially in the context of doing the imaginal exposure work. Anything to add, Julie?
No, I mean, I think that's important, right? Yes, absolutely. That CPT can be offered both in individual and group therapy formats, but PE is an individual therapy treatment. I might add, just in as we've got just a moment left, I would be curious in knowing what the audience will take away from this discussion today. I'm a firm believer that it's important to identify some takeaways, just to take this and really integrate the information. Janet and Gary, might you be able to help if people are willing to type into the chat box any takeaways from today's lecture?
Sure.
Joel
So,
is saying, oh, go ahead, Janet, go ahead.
No, you.
Okay. Joel is saying getting further trained in an EBT modality for PTSD. So happy to hear that, Joel. Yeah. Angela said, love the resource from the VA. Thank you so much. Leonard says, great session. Thanks so much. Erica, what a thoughtful and evidence-based presentation. Thank you so much. Gretchen, thank you very much for your time and bringing us this presentation. Just a lot of accolades from those. Alex says, I really liked your analogy of the wound healing process. It's also helpful to think about how to address the in vivo exposures given the pandemic. And then even more accolades from our attendees.
Well, that is very kind, and thank you. Truly grateful for this opportunity. And again, our intention going into this was that this would be helpful to those listening, and again, maybe increase access to these important and effective treatments. So thank you for the space to be able to have these important conversations. Megan, any final thoughts?
Just again, thanking everyone for your interest in this topic and willing to spend an hour with us to learn this information. And for folks who are interested in getting further training in these EBPs, we certainly hope you will consider joining us in 2021 for our next postmaster certificate in PTSD.
Thank you so much, Julie. Thank you, Megan. Really appreciate your time. What a wonderful, wonderful discussion, and the comments reflect that. So we want to just express our most sincere gratitude for sharing your time and expertise with us today. Thank you, Janet, as always, being a wonderful co-hostess. Please join us on Thursday. We would love to see you as we explore educational equity. So please, registration and more information, all available on the Open Classroom webpage at the Brown School site. Thank you again for joining us, and enjoy the rest of your day.
Thank you.
Stay well, everyone.
Bye, everyone.